And these are some of the prenatal testing that we offer to the pregnant mothers. First trimester screening is the one which first trimester, this is the screening method. Usually it is done before 13th week, and here you have to combine before telling the risk. Nowadays the reports will tell you the risk. Okay, so just I understand what we are talking about is, once a pregnant lady comes to you for a double marker or for a triple marker or a quadruple marker, understand what are these reports. Okay, what this quadruple marker means, what are the different biochemistry panels that is done, right? Even nowadays, like, our labs are very intelligent. They have given us very less work. If you just call up a lab and tell that, okay, this so and so mother is at this age and she's at 15th week, so they'll give you a panel, Down syndrome panel. Okay, 15th week, just do this panel. So we have stopped even thinking all this. Like, as pediatricians, we don't do this. This is mostly done by our gynecologists, right? So for our knowledge, we should definitely go through all this. You might ask me, why is it important for me? How many pregnant mothers I am going to see? I am a pediatrician. No, we need to know all this, right? So what are these tests based on? One is age, next is the biochemistry panel, and then third is based on the ultrasound features. So in the first trimester, what are we going to combine is maternal age, nuchal translucency. Of course, you would have done an NT scan by then, and a double marker is enough in the first trimester. So double marker is beta, HCG and PAPA, right? So this is beta, HCG and PA-PPA. So this is the double marker test which is done in the first trimester. And second trimester screening is the triple marker. So double, triple and quadruple. Double marker is only in the first. So when comes at the second trimester, we either have to do a triple or a quadruple marker. Of course, quadruple marker has one more biochemistry test which is included here. So what happens in a triple marker is our maternal age plus alpha, beta and gamma, you can understand or you can remember. So alpha is alpha fetoprotein, beta is free beta HCG, gamma is unconjugated estriol. This is how you used to remember. So this is a triple marker. For a quadruple marker, along with this alpha, beta, gamma thing, one more we introduce here is inhibin A. So the detection rate is quite high. It's right. So the detection rate, even with a double marker, when you perform it in the first trimester, it can be high up to 95%. Okay, so based on your nuchal translucency and maternal age, you can get the report. The report will tell you that so and so mother is at 1:100 or 1:500 risk of getting a child with Down syndrome. So such is the interpretation. You need not think much. What you have to do is pick up the mothers, do the test and get the report. So that is what you are going to do. If the risk is high, then we can proceed to either CVS or amniocentesis depending on which period of pregnancy the mother is. Okay. In the second trimester, the detection rate actually falls to 70%. So most of these tests, even though it is comprehensive, you have introduced 2 more tests in your screening panel, but the reduction rates falls. So always NT scan must. Any doubt in the NT scan, go ahead with the double marker test, corroborate with the age, get the screening done, and then get in touch if in case you find that this particular mother has a high risk. Get in touch with your geneticist for an invasive screening test. Okay. So why are we concerned about Down syndrome? There are lots of features we know, and some of the gene abnormalities are identified in this chromosome 21. So these genes will increase the risk of these children to various health conditions, like they have very high risk of early onset Alzheimer's disease. So this has been identified on chromosome 21 because of all these genes. I don't want you to remember all these genes. Just remember why are we so concerned about Down syndrome. And there is a very, very high risk of heart defects. We told 1/3 of the children are going to have heart defects. And there's a high risk of gastrointestinal problems, hypertension, 10 to 20-fold high risk of leukemias. This is a very sad fact. Okay, so these children have very early onset of leukemias, and some of them do not respond to our conventional protocols, transient myeloproliferative disorders seen in the neonatal period, etc. Okay, so apart from the characteristic facial appearance, we have to identify these children and identify what congenital anomalies they do have, what comorbid conditions they do have, and we have to keep them in loop. We have to keep them in follow-up to do the age-wise surveillance of these kids to identify all the risk factors. So these are the brush field spots that you can see in the iris. This is the nuchal. So whenever you examine a child with Down syndrome, so always these are some of the features. I have not put the entire image, complete images for you, but some of the images I have showcased here. So this is the nuchal fold, nuchal skin, which is very loose. This is the sandal gap that you can see here. So sandal gap is the difference, or there is a wide gap between the first and second toe. The child is floppy, that you can see here. Here the child, the newborn is asleep, and when the baby is crying, you could identify the typical features of these children. See here, you can see the mongoloid slant, there is a depressed nasal bridge, a broad facies, a broad forehead, etc. So when the child is crying, you can see that the features get accentuated. And these are the children with Down syndrome. So though they vary between ethnicity, region, gender, their appearance is typical, that mongoloid appearance. So identify these babies. So throughout their lifespan, they get a various medical disorders, and we have to be aware of what disorders can come at which age, and during the follow-up we have to keep checking. So I think I have an extensive list of this investigation. I will finish off this Hall's criteria, and then we will start talking about these medical conditions. So Hall's criteria is something that is given for Down syndrome. The higher the number, clinically, there is 10 criteria here. The higher the number, like 6, 7, 8, 9. So if it is higher, it means that the baby is diagnostic of Down syndrome. Most often we don't use Hall's criteria because it is very evident, and then when we do the karyotyping or fish, we get the report. It is quite common, but just for exam sake, sometimes it is asked also. Hall's criteria again, so starting from the hypotonia, so tone abnormality, the baby is floppy, just remember the image there. The Moro reflex is very, very flat, and coming to the face is completely flat. Eyes, there is a mongoloid slant, so this is the mongoloid slant, so there is an upward slanted palpebral fissures are present. Go to the ears, small dysplastic ears, and in the neck we just saw that the nuchal folds are very, very loose, so you can get so much of redundant skin. Come to the hands, so the hands, they have a clinodactyly, and there is a single transverse palmar crease, and if you have finished the hands, it is the joint hyperflexibility. Okay, and then go downwards, you can see that there is a pelvic dysplasia. Okay, so starting from the hypotonia, poor Moro's reflex, and then come to the face. Face is flat. Eyes, there is an upward slanted palpebral fissure. Come to the ears, small dysplastic ears. Come to the neck, and then about the digits and palm, joint hyperflexibility, and then pelvic dysplasia. So you can remember in one order to write it in your exams. So these tabular columns in the next few slides, I have around 4 slides. So these tabular columns are all from your Nelson textbook. So I will just go through it quickly. So starting from CNS. One thing is, we know that there can be a variable developmental delay and intellectual disability in these children. Apart from this, they are at high risk of seizures also. One is infantile spasms, which is very, very, around 5% these children can have. And other behavioral abnormalities like autism spectrum disorder can also be there. And of course, this you should not forget, there is an early onset Alzheimer's disease risk, which is around 50%. Okay, so in each of the system, please remember at least 2 to 3 and then write in your exams. Okay, so we have finished CNS. Next, we'll move on to the pulmonary. So ENT, all these things. So ENT, so they have tracheobronchomalicias, they have obstructive sleep apnea. See, around 50% have obstructive sleep apnea. So do not forget these two. Pulmonary hypertension also, there is a 5% risk of these children having pulmonary hypertension. Next, let's move on to the gastrointestinal. So the most common here will be constipation and gastroesophageal reflux are the most common, followed by celiac disease and Hirschsprung's. There can also be duodenal malformations in gastrointestinal. Genitourinary, of course, there can be some uretropelvic junction obstruction, some dilatations could be there in genitourinary. And cardiovascular, 1/3 of these children do have cardiac defects And among these cardiac defects, what is most common? Endocardial cushion defects or the atrioventricular canal defects. So 42% of the congenital heart disease will be definitely this. So echo at birth is warranted. After AVSD, it can be VSD, ASD, TOF, and there can be some valvular abnormalities. So this is about cardiac, pulmonary, GI finished. Then hemato-oncology, 10 to 20 times higher risk of getting hematological malignancies in Down syndrome when compared to a general population. And among these, what is most common is megakaryocytic leukemia. So all these are MCQs. So just focus on the important ones alone. So acute megakaryocytic leukemia is the most common leukemia which is seen in Down syndrome. Then there is a transient myeloproliferative disorders. Usually there is a higher WBC number with blast, but it lasts for only 1 to 3 months in the infancy period. Next, there could be ALL. So after hematology and oncology, so we'll move on to orthopedics and so joint hyperlaxity, which is one of the criteria in the Hall's criteria, that is there. Joint hyperlaxity, where it is going to be risky or life-threatening is when it involves the atlantoaxial junction. So these children are at high risk. See, 27% these children are at high risk of having atlantoaxial instability. So these children are prohibited from entering into contact sports and diving. And there could be pes planus, there could be recurrent joint dislocations and even juvenile idiopathic arthritis. Dermatology, again, some children can have alopecia, vitiligo, I think mostly hidradenitis suppurativa also. So these children are at risk of this. So eyes, we saw one in the image, that is brush field spots. Apart from that, they can have nystagmus, strabismus, refractory errors are very, very common. Most often when we see Down syndrome children, most of them have spectacles, isn't it? So there could be astigmatism, nasolacrimal duct obstruction can be present, cataracts can be present. So regular ophthalmological evaluation is important. ENT, these children have hearing difficulties and mostly it is due to conductive hearing loss. So either the canals can be stenotic, there is recurrent cerumen impaction in these children and medullary effusions also. So mostly it is a conductive hearing loss. And dental, so malocclusions, tooth agenesis, periodontal disease can be seen in these children. Coming to most importantly, endocrine. So the first test that we have to do in these children is of course the thyroid profile, right? At day 3, definitely a thyroid profile is needed because congenital hypothyroidism is so common. The risk is around 1 in 113 live births. And not just hypothyroidism, there can be hyperthyroidism also. So regular thyroid profile screening is very, very important. Even if it is not congenital hypothyroidism, there can be acquired hypothyroidism and there can be subclinical hypothyroidism also. And these children are at risk of type 1 diabetes mellitus. So these are all the clinical features that we have to see in a child with Down syndrome. So I mean, most of this is repetitive. So I'm just going to underline what are the points you have to see. So first thing I told you, they are at risk of ophthalmological complications. So initially at birth, always check for the red reflex through your fundoscope and then every 6 months, keep them in loop, keep them under ophthalmology referral and then at least every 2 to 3 years, please ask them to go to an ophthalmologist and see. So ENT, of course, initially there could be conductive hearing loss. So ENT evaluation is a must. And dental also frequently they do have problems. Coming to endocrine abnormalities, of course, hypothyroidism, congenital hypothyroidism is very, very high, 1 in 113, 1 in 135 live births. So you do take the thyroid profile test on day 3 and if it is done at birth and it is normal, keep repeating it, repeat at least biannually in this children, okay, 2 times a year. Please repeat it. If it is THH is consistently more than 10, start the treatment also. There could be hyperthyroidism, but mostly that is asymptomatic. But when you screen, if hypo is present or hyper is present. Type 1 diabetes mellitus, of course, regular screening is not necessary. At least annually once, do a sugar monitoring alone. Cardiac defects, I told you, most commonly is the atrioventricular septal defect or the endocardial cushion defects. So all children at birth should have an echocardiogram and a complete physical examination is necessary. If it is a large shunt lesions, immediately we have to do because Down syndrome children are at high risk of developing pulmonary hypertension. So immediately shunt correction is in this child when compared to the normal child with the heart lesion. Pulmonary, most commonly we see Down syndrome children in our respiratory wards, isn't it? They come with recurrent pneumonias because of their anatomical abnormality. They have some cleft, they can have tracheobronchomalaccias because of the gastroesophageal reflex, tracheoesophageal cleft fistulas. So, all these some anatomical and structural abnormalities predispose these children to get repeated infections, especially pneumonias, and they can also have immunodeficiencies. So, most common cause of infections, admissions in these children will be respiratory infections. Obstructive sleep apnea, most common. So, 70%, 80% of these children do have obstructive sleep apnea. So, we have to do a sleep study for these children at least before the age of 4 years. Neurology, I told you, risk for infantile spasm, risk for seizures, risk for autism, early onset Alzheimer's disease and early onset stroke. Gastrointestinal, two most common is, one is constipation, another is gastroesophageal reflex. Of course, celiac disease is common, but even AAP do not recommend that you routinely do a celiac screening. Only when you find that there are certain clinical features relevant to celiac, we can do. And how to support these children is, initially in infancy they don't take nutrition properly, so they are at failure to thrive. So during the infancy we need to give thickened formulas, nasogastric feeding if possible, or low flow bottles, slower paced therapy. How do you treat a gastroesophageal reflex? And similarly we have to treat this children also. But in late childhood and adulthood they are at risk of obesity. So in infancy it is failure to thrive, and in late adulthood or childhood it is obesity, because these children have decreased basal metabolic rates and their activity level is also low. Genitourinary, I told you, mostly it is these obstructions that can come, and some renal abnormalities like IgA nephropathy can also be there. And testicular tumors are at high occurrence in these children, 5 to 50 times higher. So, early testicular examinations, if we don't do, we would be missing it. So, physical examination is fine. Down syndrome males are sterile. Down syndrome females, they have irregular periods, but with treatment they can get pregnant. So, hemato-oncology, I told you, 20 times the Down syndrome children are at very high risk of developing acute leukemias. And among the leukemias, what is the most common type? It is acute megakaryocytic leukemias. But this megakaryocytic leukemia is very, very sensitive to treatment, and it has got a good prognosis. Say you do a CBC at newborn, definitely you have to do. You can find blasts, you can find neutrophilia. If it is a myeloproliferative disorder kind of a picture in the newborn stage, it could be TMD, which is the transient myeloproliferative disorder. This also mostly resolves, 80 to 90% it resolves in the first 1 to 3 months. Beyond that, some children can develop into AMKL, which will be amenable to treatment. And with respect to the immunology, some children have B cell and T cell lymphopenias, predisposing them to an immunodeficient state. Autoimmune disorders also, they are at high risk of JIA, thyroid disorders, celiac disease, alopecia. So, some autoimmune disorders that we commonly see, right? Type 1 diabetes mellitus, celiac disease, all these come together. So, they are at risk. So, whenever you screen for diabetes, screen for other disorders also. Routine screening for celiac, JIA, SLE is not needed. But when we do catch celiac disease, do screen all these disorders at once. Musculoskeletal, I think mostly, which is already told. Universal neck precaution is very, very important because of what? I hope you remember, atlantoaxial instability. Why am I rushing? Because all these are known to you and we just saw all these, right? Atlantoaxial instability. Dermatology, most commonly these children, you say, very silky hair, very, very less hair, and some children can have vitiligo also, and there could be hidradenitis suppurativa. So, remember 3-4 clinical features in each heading. I wanted to identify certain features around here. All these, again, these are from our Nelson textbook, but again, very vast, very particular percentages are present. I want you to understand that how will be the motor delay, how will be their intellectual disability. Okay, so I am just giving you this very, very salient points here. So, usually there is a delay both in the motor, that is gross motor, and the fine motors. How is the delay? Gross motor is usually mild delay, mostly. At 2 years, 25% of them will walk, and beyond that they will start walking slowly. And speech is delayed in these children, both receptive and expressive. Okay, and 50% of them will have a moderate intellectual disability. 25% have mild and 25% have severe intellectual disability. Whenever we see these Down syndrome children, they're always smiling, right? They're always smiling, very, very sociable children. So they have high sociability and they have joint attention. I mean, they can combine stuffs. They have strong imitation skills and very, very empathetic children. And so very happy, go lucky kind of children they are. And only when those subset of children who develop these ASD kind, they are only very restricted. Most of them have good social interactions. And even though intellectual disability, 50% have moderate one, but the IQ usually declines throughout their childhood. Their strengths are in the visuospatial sequencing and non-verbal memory. But apart from that, their working memories, their explicit memory, their verbal processing, short-term memories are all weaknesses for them. So these are all other behavioral disorders. Some of them which we commonly see is autism spectrum disorders, and some children being hyper attentive or hyperactive. So how are we going to follow up these children? This particular tabular column is from the IAP's consensus statement of the Neurodevelopmental Pediatrics of IAP chapter. Okay, so this is taken from the Indian Pediatrics Journal, February 2023. If you want to go through that article also, it is available free online, so you can go through that article also. So this is a very beautiful article. Just 2 years prior we had this article. So I just put up this tabular column only, so remaining you can go through it. So what are we going to do? One thing is, you know, you are expecting a Down syndrome child because already there are combined tests you have done, quadruple test, everything you have done. So when you're expecting the delivery, you know it is a Down syndrome baby. So at birth, take the sample, send the baby's karyotyping in case already it is not done. In case there was no CVS, no amniocentesis is done. I mean, even if it is done, we have to do, right? So even if it is done, we have to establish the karyotyping for this child. And then at birth, what you are going to do is CBC, peripheral smear, and do a thyroid function test. This is important. So these are the blood tests. Next, do an echo, rule out congenital cardiac defect. If it is present, what kind of a defect? If it is a large lesion, operate. So get in touch with the cardiologist. ENT evaluation, ophthalmic evaluation, dental evaluation must. Dental only at 2 years, I'm sorry. So ENT and ophthalmic evaluation is a must. And of course, all the growth parameters. Testicular examination also from the 2-3 years. Okay. So at birth, karyotyping, CBC peripheral smear, thyroid profile test, and ENT ophthalmic evaluation. So beyond which, have this tabular column in your, in the patient's file only. So whenever they come for follow-up, so you will have to follow it up accordingly. So most often we do the CBC peripheral smear and thyroid function test almost every year. We keep doing it. Okay. And yeah. So this is the end of Down syndrome presentation. I think I have not confused much. I have given only salient points here, and this is something which should not be missed. Any point you fail to understand, or if you feel that I was not clear, if you want me to do it again, you can give us your feedback. I'll be happy to work on it again and make it clear. Okay. So meet you in the next video lecture. Keep listening and keep supporting us. Thank you.